sanaa ya uuguzi wa haraka. This is how it will be. It would be.
Okay.
This is it would be sanaa ya uuguzi wa haraka, art of emergency nursing.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everyone, Kevin McFarland here, and welcome back to the Art of Emergency Nursing podcast. I want to take a second and let you know that Apple Podcast has done a bunch of updates. If you haven't seen it lately, you should go check it out. Now you follow a podcast instead of subscribing to them. So as far as I'm concerned, you can call it whatever you want. Follow, subscribe, do whatever you want to do. Just make sure you don't miss any episodes of the Art of Emergency Nursing. While you're there at the iTunes website, don't forget to leave a rating and review for the podcast. That is one of the best things you can do to help people find this podcast, is leave a rating and review. It's a great thing you can do for the Art of Emergency Nursing, and I really appreciate it when you do that. Another way you can help the show is by spreading the word and sharing this podcast with your peers. You know what I always say. Share it with people you like, people you don't like. Share it with everybody. On the podcast today, I have a great episode with a super interesting nurse. I've always been a little jealous of people who are bilingual, and my guest this week is not only bilingual, but he's multilingual. I guess you'd have to be when you work in a country that could have up to 43 dialects coming through your emergency department. My guest this week on the podcast is a nurse from Kenya in Africa who has a passion for emergency nursing. His passion, you are going to feel it coming through the podcast. You're going to love this episode with my friend, David. So go ahead and tell the audience who you are and what you do.
So my name is David. I'm an ER nurse in Kenya. I've been an ER nurse for the last 3 years.
Awesome.
And I love it. I love it in the ER.
What made you decide to become a nurse?
I think I just love to be in the medical field. So I chose to be a nurse because I really love to be in the medical field.
Yeah. How long? And you said you've been a nurse for about 3 years?
Of course. Yeah. True.
In the ER the whole time?
The whole time. No any other department, just the ER.
Good for you. And how big is your emergency department?
Big capacity of 25 patients. Yeah, 25 patients.
25 patients? Okay. All right. And are your doctors there in the department with you the whole time, or do they kind of come and go, or?
All through the whole time. It's a referral tertiary facility.
Okay.
So we have doctors all through.
Nice.
Exactly. Nice. Residents, consultants, senior house officers.
Awesome. That's cool. And what's and about how many patients do you guys see a day?
Like today was 200.
Woo. That's a lot. In a 25 bed ER. Busy. You're pretty busy.
Yeah, very busy.
Okay, that's awesome. And what are your requirements for a nurse to be there? Do they have to have ACLS and PALS and all that stuff? Do you guys do that there in Kenya?
Yeah, you have to be AHA certified with the ACLS, BLS, PALS, TNCC. We call it ATCN here.
Okay.
And we also have like a higher diploma, like a specialty for emergency nurses.
Oh, okay.
Yeah, and we also have ICU nurses working in the A&E. But the bare minimum is just those certificates, the ACLS, PALS, ATCN, and your basic nursing.
Gotcha.
So if you have ER nursing, that's an added advantage. If you have ICU, it's also an added advantage as well.
Okay.
But at least you have to have those certificates.
Gotcha. So the specialty in emergency nursing, is that like the CEN, like internationally? Or?
Kind of, exactly. Most likely like CEN.
Okay. Yeah. All right. That's cool. That's really interesting. So what made you decide to do the ER?
I felt like in the emergency, it's dynamic and you don't get to stay with the patient for long. And also I love, I'm an adrenaline junkie, so I just love working in a fast-paced environment. So I decided to be an ER nurse.
Absolutely. It's a perfect place for an adrenaline junkie, isn't it?
Exactly.
Perfect place for an adrenaline junkie.
Mm.
And what did you do before you were a nurse?
Um, I was schooling. I was in high school. Then I
Okay.
joined nursing school immediately after high school.
Okay.
And so all my life was schooling and then job. Nothing else after out of that.
Gotcha. So you go right from high school to college.
Yeah.
All right. Good for you. That's the way to do it. So
I think I was proud. Maybe I was lucky, not proud. I was lucky. Maybe
you were what?
I was probably lucky.
Oh, gotcha. Yeah, lucky. Oh, yeah, for sure. I think it's a good thing to be able to go right into nursing. Like I was late. I didn't become a nurse till I was like 30. So I was,
really?
I was a little later in life. I'd done a few other things before I decided to become a nurse. So, and I wish I would have done it sooner.
What happened? What were you doing?
I was doing a couple of things. I finished high school and I started taking some college classes, but I wasn't a very good student. I wasn't very focused. So I didn't really drop out, but I just never really put a lot of effort into it. So I kept kind of taking classes and I ended up becoming an EMT and worked as an EMT for a little while. Did that for a while and worked in the hospital. And then that really kind of started getting me kind of encouraged to go back to school and get my nursing degree. And then when I finally decided to get serious about school, I found a job where I could work a little bit less and make a little bit more money and give myself a little bit of bandwidth to go back to school. So I didn't go back to school. Gosh, I went back to school probably like in my mid 20s and was a much more focused student. Like I was much better than I would have been at 18. Like I wasn't focused enough at that time. So I think I finished. Gosh, I think I was probably like in my 30s when I finished, and that was okay. It worked out pretty well. So.
And you're a bit serious.
Yeah, I was a little bit more serious. Exactly. It took me a little while. So, but I wish I would have done it sooner, like you. I mean, certainly see people who've done it go right into it, and that's a good way to go. That way, you get started a little earlier, and your experience, you'll end up getting a lot of really great experience that way.
Very true.
Yeah. So
here we've been taking care of patients with strokes, MI, septic shocks, upper GI bleeds, all kind of everything that you know in this world.
Yeah. Have you guys seen a lot of COVID patients?
A lot, like thousands of them.
I bet. And what about now? Are your numbers for COVID patients going down?
Yeah, right now it's kind of coming down, but like 2 weeks ago, there was a surge and the whole country was like, it was hectic. So many patients, COVID patients requiring a lot of ICU beds, and there was a crisis. But right now, the numbers are coming down.
Calming down a little bit now. That's good. That's a really good thing.
Yeah.
Are you guys getting vaccinated yet? Has the vaccine made it there yet?
Yeah, we got vaccines a month or two ago. And we've been getting the vaccines, so it's going on well. That's good.
Are most people in the country looking at getting it? Like, do you have a lot of people who want to get it, or are there people who are hesitant?
Yeah, some are hesitant, some are taking it because of the story we had about cloud formation.
Are you guys doing AstraZeneca?
Yes, I believe that's why people are feeling, not comfortable, but majority of the population have taken it. So that's good.
That's really good. Yeah, that'll help get the numbers down.
Exactly. But you see, with that kind of information, people tend to withdraw, but majority are actually accepting the vaccines, majority of the people.
That's good.
Even those people who initially were skeptic are now taking it. So eventually, we'll vaccinate the whole population.
That'd be fantastic. That'll help a lot. So
exactly.
What? Tell me about a patient. Tell me about a patient that changed the way you practice. Tell me about a
A
patient.
patient that changed the way I practice.
Yeah.
Oh my God, what a question.
Tough one. It's a tough question.
Some few years back, I got a patient who was in there were some spots in our city center, and this guy came with stroke, symptoms suggestive of a stroke, and I was a new grad, so I was kind of learning things, the year things. So that patient had a lot of deficits before we did the CT, but right after TPA, the guy got like an NIHSS score of like 3 after TPA.
Wow.
So I was surprised because right immediately after the TPA, everything changed and improved. So I think it got me to realize that time is brain, and the faster you act, the better the outcome.
Absolutely. Absolutely. Isn't that an amazing drug? What an amazing drug.
Yeah, I was actually surprised because the deficits before TPA and deficits after, it's amazing. It's just amazing.
Yeah, it's the first time I seen somebody have a really positive outcome with TPA. I was just like, wow, this stuff is cool.
Exactly.
Because I mean, I think even more so than having an MI, like strokes scare me. Like I would be terrified to have a stroke. Like that would be right. Like that'd be the worst. Like it's one of those that you're like, oh man, you just think that that's going to be something that it's just so life changing for people. How life changing it is. So
exactly.
Tell me about tell me about the first time you made a med error.
I made?
Have you made a med error? Can you tell me about the first time you made a med error?
Med error, I wouldn't call it an error. Maybe it was a near miss.
Okay.
Yeah, because I went to it was an emergency, so I went to the pharmacy, so some drugs were dispensed. The same thing, the same scenario. I went to take, it was an MI. We used Metalase for MIs and Actilase for strokes.
Okay.
So we have prepared some boxes with everything that you need for, so we call the MI box and the stroke box. So I got the wrong box for them. So, but I realized before administering, so because of the simple thing, the 5 rights, like knowing what are you giving, what is it that you have in your hands. Exactly. So the 5 rights, I think were it not for the 5 rights, maybe I could have administered the drug. So that is one of the grievous mistakes that would have happened in my life.
Yeah. Yeah, it's those near misses are always scary. You're like going, "Ooh, if I wasn't paying attention, that could have been bad."
Exactly.
Could have been bad.
Mm.
So, tell me a little bit about the healthcare system in Kenya. Is it a private system? Is it a public system?
So it's mixed. It's private and public.
Okay.
It's so public hospitals. We have level 6, which are the national referral hospitals. Then below them, level 5s, which are like regional, like county referrals.
Okay.
And then level 4 and level 3s are a bit lower. And then level 1 is the dispensaries.
Okay.
And then we have also faith-based. We have private entities. Yeah.
Okay. So in the public hospitals, is it free to get care, or is it paid for? Is it paid for by your taxes or whatever the case may be, or how does it work?
So for the public, it's like almost free. It's very cheap, like affordable for everyone.
Yeah.
But the private sector depends on your financial power. So because they're expensive and a moderate fee, and then cheapest.
Gotcha. And how and so do most folks get primary care? Do most folks have a primary care doctor? Do they use the emergency department as primary care, or how does that work?
Primary care, you mean like someone with a private doctor?
Yes.
Not really. Not majority of the population, no.
No. Okay.
No. But so maybe those.
So if they need care, do they just come to the emergency department and do
They just come to
episodic
the
care?
ED. Yeah, they just visit the ED, the nearest ED, and get care.
Okay. What if they need meds? Like, what if they're a diabetic and need to see a doctor regularly? Is that common? Like, do they have access to seeing like a regular doctor that they see all the time?
No, not all. Sometimes they have their regular clinics.
Oh, is there regular clinics too? Okay. So they'll go to the clinics.
I lost you.
Oh, are you there?
Yeah, you're back now.
Okay. So they'll go to regular clinics to get care too. They have like just kind of like minor clinics.
Yeah, if you're diabetic, we call them diabetic outpatient clinics. If you're hypertensive outpatient clinics, and so on and so on. So they normally, that's where they kind of get their primary care.
Oh, okay. Okay. So
Because
they
call it my doctor is so and so and has been following me up for, yeah. So that's how they get their meds and everything.
Oh, okay. Okay. I guess that's kind of what I was asking. Okay, cool. That's awesome. So do you find that most people who come to the emergency department truly have emergencies then? Like that?
Yes.
Do they not? Okay.
Mm.
And do you guys have a lot of problems with like drugs or alcohol? Are those issues there in Kenya?
No, not really. Not really. It's not common.
Not common?
Yeah.
Okay.
Drugs, not really. The last time I saw an alcoholic, it's been a while.
Wow. Okay. Okay. And what about drugs? Are drugs an issue in Kenya at all?
Drugs, it's not unless in some parts, but where I work, it's not very common. Sometimes I used to hear that it's common in Mombasa, but in Nairobi, it's not really common.
Oh, okay. Nice.
So we don't get cases of drug overdoses, not quite common.
Okay.
I think I have seen one in my life, in my entire nursing life.
Oh, really? Wow. Okay. That's kind of cool. That's kind of cool. What kind of traumas do you guys get? Do you get what kind of traumas like a common trauma there?
Motor vehicle traumas are the commonest.
Okay.
With injuries in every system of the body.
Oh, I'm sure.
Yeah.
Do you guys have a lot of problems with like violence, like shootings, stabbings, anything like that?
Well, those are unheard of, not quite common, but maybe stabs. But no. Like I have had only 2 stabs in my entire 3 years.
That's not bad. It's not bad at all.
And shooting, never.
Never.
Unless someone, there's one who shot himself. So,
okay,
like he was playing with his gun and shot himself. So gun violence is unheard of in Kenya because I think it's well controlled. There's not that freedom of owning a gun so much.
Okay.
So I think it's a good thing.
Yeah. Okay. Yeah. That's a big difference from America.
Yeah, I know.
Big difference from America. So
yeah.
Nice. And when you said you took ATCN or TNCC or one of those?
ATCN.
Okay. And how did you like that course? Good course? Did you enjoy it?
Wow, it was a game changer.
Yeah. That's awesome. That's awesome.
Yeah, the way I before and after learning it, I think I learned a lot about the emergencies, what kills the patients first.
What is the primary languages there in Kenya? Like what languages do they speak?
Oh, there are so many, 43.
Ooh, 43, that's a lot of languages.
43, but what do we say? So I haven't counted Swahili and English.
Okay.
Because Swahili is a major, like a regional for the East and Central Africa. And also English is now everywhere.
Oh, really?
Yeah. Okay. So at least everyone speaks English.
Oh, really? Interesting.
Yeah, majority of the population, now that we have free primary education, like English and their local language, and you find like you speak another language or 2 or 3 with the same dialect.
Okay.
So we are so multilingual, but I think you guys also are so multilingual because you can speak Canadian, you can speak British, you can speak Australian, you can speak American.
I guess when you put it that way, now I feel better about myself being multilingual. Now I feel better about myself because I speak English and that's it.
I know. You are so monolingual.
So
maybe Spanish. Some Americans speak a lot of Spanish.
That's true. I used to be able to fake my way through a triage with Spanish, but probably not anymore. It's been a while. So what other languages do you speak?
So I can speak, other than Swahili and English, I can speak Kikuyu, can speak Luya and Kamba.
Okay, so those are just different dialects. Are they pretty close together?
They are close.
They're close. Okay. All right. That's kind of cool. Yeah. What's your favorite part about being an emergency nurse?
My favorite part is saving lives. It's pretty satisfying to see someone dead and alive again.
Yeah.
I had a patient. We have these code blues that we respond to. So I responded to a code blue. Someone was seated in Java taking coffee. I responded to that code. I came back to ER, compressing on the ER on the stretcher. That guy went to ICU, was discharged. After 3 months, came back to say thank you with a big cake.
How cool is that? What a cool feeling. That
was so satisfying.
Oh, I bet that was so satisfying.
Exactly, and we did anything that you've seen in the ACLS algorithms. So we shocked with it. I've never seen such a positive outcome.
That's incredible. You don't see that a whole lot. That's really nice to be able to see.
Yeah.
How cool is that? So when you said you responded, was he in the hospital somewhere and then you responded, or do you guys go out on an ambulance?
It was still within the hospital, but away from the ER. Like there's a Java, so people take coffee there within the hospital. Like right within, yeah.
Wow. How lucky for him to have that heart attack there.
He was so lucky, and we have cath labs, so he was in the right place at the right time.
Do all the hospitals have cath labs, or just some of them? Some of the bigger ones?
Some of them, not all. Some of the big ones.
Okay. How big is your hospital? How many beds? For your whole hospital?
Huh? 280.
280? Yeah, it's a pretty big hospital. Yeah. Is it the biggest in your area, or is there a bigger one around too?
It's the biggest in East and Central Africa, like not in terms of the structures on how many beds, but in terms of what we can do for the patients.
Oh, okay. So one of the more complex centers. Nice.
Sorry?
It's one of the more complex centers where they have the best care?
Yeah.
That's cool. That's really
cool. They can get everything they want because you have all the consultants, plastic, neuro, everything.
Wow, that's cool.
Yeah.
That's really cool.
We don't refer. We have the capacity to manage everything.
Yeah.
Maybe bands because we only take 10%. We don't have a band center.
Gotcha. And that's very specialized, isn't it? Where do
exactly.
you guys?
And I find it so complex.
Yeah. Where do you guys send your burns?
The government national referral hospital.
Okay. Okay. All right. So, and is that far from you, or is that a far
10 minutes transfer? 10 minutes drive?
Oh, that's not bad. That's not bad at all. Now, do you guys have an EMS system there in Kenya? Like, do you guys have EMTs that go and pick up people?
Yes.
Yeah, you do?
Yeah, okay. We have EMTs, we have paramedics.
Oh, nice. Very cool. And then do you guys do, is air transport a thing there? Like helicopter transport, helicopter medicine?
Yeah, we do, but not so common.
Yeah.
We do private, it's private entity. It's a private thing.
Oh, okay. Okay, probably very expensive.
Yeah, it's very expensive. I think not everyone can afford it. So it's for those who can afford it. It's a bit expensive.
Yeah, I bet.
I even don't know the cost, but I think it's expensive.
Yeah, I would imagine so. So I know it is here. So.
Oh, it's expensive as well.
Yeah, very expensive. Yeah.
I thought it's the order of, like you guys, that is so common in your setup, right?
It is. So but so many people are insured. So the insurance ends up paying most of it. for your insurance ends up paying most of it, but it is very common here, more common than it probably needs to be. But it is pretty common here to have helicopter medicine, and what they do is they do a lot of scene response. So you don't even get a choice of whether or not they're going to pick you up. If you're far away, then they're going to be the ones that come pick you up. So, and then the transfer piece, like, a lot of times that ends up being picked up by the healthcare insurance that most folks have. So, but if you don't have insurance, it's very, very expensive. So
I actually thought it's very affordable to have that. I think I thought maybe it's catered for by the government.
No.
But I came to learn that healthcare in America is so expensive.
Healthcare in America is very, very expensive.
Expensive.
And most, like I said, most people are insured, but even then, even if you have insurance, you still pay a lot for your medicines and a lot for your treatments. You pay a lot out of pocket as well still. So
I was following up state healthcare in the States and about Tana, and there's something I didn't quite understand. I think it's HIPAA or something.
HIPAA, yeah. So HIPAA is a law that basically says that we got to keep your health information private. So it means that if I have your health information, I can't share it unless there's a good reason for me to share it. So I can't just go out and say, tell the media, hey, David was here in the ER and this is what he has and this is what's wrong with him. So what it does is it protects the privacy for folks, so that we're not just sharing secrets, that people wouldn't necessarily want other people to know.
That's great. And I think the other, I think one of the advantages that you guys have is that you speak one language and everyone understands it.
Mostly.
And like English, most of them.
Most, yeah. Though we have a big Spanish-speaking population here too. So.
But not big as English. Maybe not even 10%.
I don't know. Maybe more than that. Maybe more than that. But most end up speaking some level of English to some degree.
Spanish is spoken by we call them Hispanics.
Correct.
There is another name. There's the Black population. There is. I think it's the Hispanics. So I think the Hispanics population is 3%.
I don't know. I'd
Black
have
is
to look
14.
it up. Oh, okay. Is it?
Black is 14.
Yeah. What's kind of interesting, it kind of depends on where you go too. Like I think Houston has a very large African-American population, a Black population, and then a very large Hispanic population too. We're very international in Houston. Let me look at
and diverse.
Yeah.
So I think that so to disseminate information here in Kenya, you have to go. Although the older generation is somehow not English speaking, because in those days they never used to treasure education, and not most of them don't understand English. So to disseminate medical information, you have to translate from English to the local languages. And so that's why I think it's the challenge to disseminate information unless you translate. And to catch a good population, you have to change in each of the languages. So I think that was one of the challenges that we face, because for like you guys to disseminate anything about health, you just need to put billboards or national TVs maybe. Yeah,
and they certainly do that. But Houston has about 2 million people in it.
2 million?
Yeah, in Houston. In the city I live in now.
Houston, the city.
The city has 2 million. Yeah, it's got a lot of people. Very, very popular. I was just looking at the demographics, and it's 50%, 57% is white, and 22% Black or African American. And then Hispanic, it says Hispanics about 45%.
Wow.
So very
almost
large,
like the whites.
Very large population. Very large.
The minority majority.
That's right. That's right. But a lot of those people a lot of those people say that they're both. They'll say that they're both Hispanic and part white. And then we have a high Asian population here too. It's only about 6%, but there's a lot of, it's very very diverse. We in the medical center of Houston, where all the hospitals are, it's very diverse. So
that's quite different.
Yeah.
And the other thing I find different is the academic ladder, because in Kenya, once you're a nurse, you will always be a nurse. So we have education from what you guys consider you call ADN. We call it diploma.
Okay.
And then you have the degree, and then the master's and PhD.
Okay.
But here is the difference. You guys, if you do your master's, you become a nurse practitioner. For us, you can still practice in a clinic, but you have to have like 5 years experience to own, but that will be like a clinic for you to own and do clerking. But because I feel like nurse practitioners function more like doctors.
They do. Do you guys use nurse practitioners in Kenya?
No, it's not even in the curriculum.
Okay.
So that's another difference I've realized, because I think in Kenya, once a nurse, always a nurse.
Yeah.
Like there's no, okay, even nurse practitioners are also nurses, but the way they practice is not, if they were in Kenya, it wouldn't be within the scope.
Gotcha.
Prescribing, seeing patients, all that. Yeah.
Do you guys use physician assistants?
Maybe that would be guys called clinical officers. They're like doctors, but half-baked. Yeah, so
okay.
Yeah, I would consider them as physician assistants.
Yeah, and that may be similar to what the physician assistant role is here in America.
Yes.
So, now, speaking of like the money piece, how much do nurses make in Kenya? Like, is it a good living?
How do I tell you this? It's between $500 to $1,000.
Per what?
Per month.
Per month?
Yeah.
Okay. All right.
$500.
And is that considered a good living in Kenya?
Yes, you're rich.
Okay.
Like for middle class, that's middle class.
That's middle class.
If you add that, you're middle class.
Okay, fair enough.
Yeah.
And I think nursing for the most part here, most nurses make probably about $30 an hour. So let's do the math. Let's see. Most nurses make about $30 an hour, about $30 to $40 an hour, probably. So they make about $1,200 a week.
A week.
And then
in US.
In US. And then
so that's what we make for a month. Even less. We make way less than that
a month.
For a month.
Yeah. And then keep in mind that the government takes about a third of that in taxes.
You also take a third of ours, because they take 30%. They take 30%, which is also a third.
Yeah. Ours is about 30% by the time it's all said and done. So,
yeah.
But and some nurses make more than that. I mean, it's not unheard of to have a nurse making about $50 an hour. So
I've had nurses in California and New York making $60, $70 an hour.
Yep. Yeah.
That's crazy money.
Yeah. And now with COVID, there's a lot of places that are making, they're throwing money at those guys. They're getting.
Yeah. My friend was making $100 per hour.
That's crazy.
That's a lot of money.
It's a lot of money. So
and I also realized that there's this thing in ER, we say don't gist the shift, like don't talk about how come the shift is. I found it's also in America. Yep. Don't talk about a calm shift.
Yep.
You just
you'll jinx it. You'll jinx it for sure.
Yeah, you jinx the shift.
Yep, absolutely right. That's a true thing. Now, do you guys have a busier day? A day that's busier than others?
Yeah, it depends. ER is dynamic. Sometimes it's cool, but almost like we get, sometimes the mornings are calm and the afternoons are crazy, or vice versa, or the entire day is crazy. And sometimes the days are cool and nights are busy, or vice versa.
Yeah.
Because ER is so dynamic and you can't really tell when an emergency is coming.
Is there a day that's busier than others though? Like, are you guys busier on the weekends, or are you guys busier during the week?
I feel like it's a mass casualty every day.
Okay.
Yeah.
Fair enough.
It's quite busy.
Yeah. Sounds like it. Sounds like you guys are seeing a lot of people in a little 25-bed ER. But what advice would you have for a brand new emergency nurse?
Be swift and be safe. Like, you act fast, but do not forget the safety bit of it, because you can take life thinking you're saving a life.
Absolutely.
Yeah, right. Because you might give the wrong drug, you might do the wrong thing because you're doing it so fast. So be swift and don't forget about safety.
That's good advice. Absolutely. Absolutely.
I think we and also listen to your sixth sense, because the God talks. The God talks.
The gods do talk. They do. It's funny how that works. Like, sometimes you're like, oh, wait, this doesn't feel right. You're like,
yeah,
okay.
Exactly. Yeah.
Yeah. I think that's
so, because sometimes there is always that thing that you've had an experience and you know what happened. You know how it went. So you prevent from getting worse. And from the word go, I've seen doctors listening to nurses most of the times, because I think nurses get to stay with patients a lot.
Yeah.
Yeah.
Absolutely.
So do you guys do cannulation and get blood samples every time you get a line?
Every time. Yep.
Every time?
Yeah. Do nurses do that in Kenya?
It's a nursing procedure. Cannulation is a nurse's thing. Like,
yes.
Yeah.
The doctors don't do it at all.
Yeah.
Very rarely do the doctors do it.
We do fixed catheters, urinary catheters.
Mm-hmm. Yep.
Such things, unless so we leave intubation and chest tubes and those complicated procedures to the doctors.
Yes. Yeah. Same here.
I would intubate. But it's not within if there is, because I've been I also train in CLS and those things, so I'm well versed with those things, intubation and things. So, but it's not within the scope. Unless it's an emergency, no one else to do it, maybe I would do that. Yeah. But not within the nurse's scope. I believe it's the same in the US.
That's exactly the same in the US. In the US, that's a physician level thing.
Task.
Yep.
Yeah, but I like the way you have certifications like the stroke, the SCRNs, the CNRN, the CCRN, all those. It's just a good idea, a brilliant idea. Whoever came up with that was great.
There's so many certifications, but it really gives you a chance to study for your specialty. So even if you don't have that test, you can still study for it. And even, that's the kind of cool thing is you can learn a lot. You can learn so much. You learn so much just by studying for it. So
exactly.
Now you were in Pam Bartley's study group, weren't you? You were doing something with Pam Bartley?
Yeah, I was trying to get the TCRN, but I then realized that I'll have the cert, but no one would recognize it in Kenya. Maybe if I get to come to the States, maybe that would be a great idea.
Yeah. Are you involved in ENA at all? The emergency nursing system?
I'm a member.
Oh, good.
I'm a member of the Emergency Medicine Kenya Foundation, which is the only emergency medicine organization.
Oh, cool.
In Kenya. So we've been having these conferences. We've been meeting delegates from all over the world. We have a lot of doctors, emergency doctors from America and emergency nurses. We've gone to Uganda. We've gone to I think we're going to Ghana next. We've been to Tanzania. We've been to Rwanda. Like we join all the emergency foundations in Africa come together.
Oh, that's awesome.
And then we get to meet in one destination.
Now, do you find there's a big difference in nursing between, say, like Kenya and like Uganda or Kenya and Rwanda? Is there a big difference in emergency nursing in those places?
No, as you said, it's only the accent. The EMS system, everything's still the same. The only difference is the resources.
Yeah.
Maybe that bit, because some are well fitted with equipment and others are limited.
Yeah. Now, so one of the last questions I always ask everybody on my podcast is I always ask them to tell me 3 things a new ER nurse should always remember, 3 things to always remember, and 3 things to just go ahead and forget.
3 things to always remember and 3 things to forget.
Yes, as a nurse, as an ER nurse.
Sounds easy, but hard.
It's hard. This is the hardest question.
Yeah. Oh my God. So I think one thing is the safety bit. Always remember safety.
Yes.
Okay. Because you have to do the 5 rights, medication safety, anything about safety. And I think that in our case is taken care of by the IPSGs. We do have the IPSGs because we are JCIA certified. So that makes it easy. It's in our blood. It's our culture. For
JCS. What does that mean? JCS certified.
The Joint Commission International Accreditation.
Okay. So you guys do Joint Commission as well?
Yeah, we do have it in our hospital.
Okay, awesome.
What else? Safety. Listen to the 6th sense.
Absolutely.
Mm-hmm. Because a patient might come again, but you might be dismissing them like you are nagging, but there could be something.
Could be something.
Yeah. What else? Never forget. Oh my God. I've never thought of that question. So.
It's a tough question.
Yeah. Never forget. Never forget. And learn always. Learn. Because it's dynamic. You get new things. And because I have been attending these conferences and we get updates before they get to the books.
Yep.
So always learn. Never stop learning. Learn always, every day. Because like before these changes gets to the books, that takes quite some time. It might take years.
Yep.
And you're still practicing the old practices. So learn and be well informed. Be versed with current affairs.
Absolutely.
Because medicine is dynamic, and more so emergency medicine, very dynamic.
Very dynamic.
To forget, that would be forget the bullies. They are the bullies. Maybe the senior nurses. Maybe sometimes they may bully you or maybe intimidate.
It's sad. It's sad that that's a universal thing. Like that happens everywhere. That's sad.
It doesn't happen only in Kenya. It's everywhere, and not only in emergency departments. It's in all departments.
Yes. Yep.
And also, if you've done a mistake, forget it. Make yourself better. So that's also something to forget. And also, maybe you can help me.
It's okay. This is all you, my friend. This is all you. So
yeah, that was quite interactive. I loved it.
That's hard. Yeah, this has been a lot of fun. It's been a lot of fun.
Yeah, I love it. I wish you could do some, not only about nursing, but life. Generally, like life in America, life in Kenya.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.